And to start the section, we got the first speaker, Dr. Kiattisak Hongku, one of the expert in terms of complex procedure, and will present the first lecture, treatment option for type I1 endoleak, please.
Thank you. Thank you, Dr. Bun and Dr. Kwang, and also Medtronic for organizing this conference and also inviting me for this session. So my topics here. So let's start with the case here. It's 80-year-old male. He underwent fever many years ago, and also with right internal embolizations, and his endoleaks at the first of CT with the minor endoleaks at the proximal neck, and then he was followed up at the second CT. The endoleak disappeared, and also have a new endoleaks at the third CT at 1 year. At that time, there's no type 1A endoleaks, but just only the type 2 endoleaks. So he intervened embolization for his endoleaks, and then next follow-up in next 2 years, at the 3 years, the sac expand, and he was scheduled for re-interventions. At the re-intervention sessions, there's no endoleaks seen by the conventional angiography, but intraprocedural CT shows some branching of the endoleaks at the proximal neck. So we still consider that he has a major endoleaks. So we scheduled for the type 1A endoleaks repair, but the patient came back with a rupture first. So another case, 74-year-old with a similar situation, with underwent type 1B endoleak. It re-intervention many years ago, and then lost follow-up for 2 years and come back with symptomatics. Just also the same, he collapsed before the schedule. So that's why we have to fix this one endoleaks seriously. And the guidelines still recommend to do all the type 1A endoleak to be fixed. Quick look at the type 1A endoleaks mechanisms. If we look at the landing zone and the short proximal C zone at the time of the endoleaks. So if we deal with the short landing zone, two situations. We have dealing with the short neck already at the beginnings, or we have a new neck degenerations. Or if we have adequate ceiling length, that the problem of the position of the graft might be the barrier with the calcium or thrombus, or we're treating a non-parallel neck, or with the angulations, or with the degree of oversizing that too much. So that will be account for the early endoleaks if we deal with a very short neck or some problem at the beginnings. But with the neck degeneration, we get late endoleaks because this also the hostile neck already at the beginnings. For the short proximal necks, so dealing with the 4 to 10 mm is too short and unsuitable for EVA without any adjunct. But it's probably with adjunct, it might not be too short. We see it again. And with this one, if actually the neck is not short, but technically we did the graft not so good, so the graft we placed a little bit low, and we get the neck with an inadequate ceiling zone at the proximal. And some of the graft over time it's migrate, and as in these pictures, it migrate and down, and the level of the renal is just a bad stand over there. In some situation with the malposition to the aortic wall, this is hostile neck anatomy with the non-parallels, angulation, oversizing too much, also with the undersizing, also with some barrier. At the time, probably we get some problem like this with the infolding of the graft if the graft is not placed properly. And look at the axial scan, you can see some infolding, some fabric at the neck, and that causes endoleaks. So we have to look at this strategy to fix this problem with the malposition. If we still have acceptable neck, that but with the barriers, with some calcium infoldings, or with the pre-existing stent, sometimes with the cuff, so we have to enhance the apposition of the necks. Also, can do embolization of the gutters of the gap between the graft and the wall. But if we don't have that, we less favorable shape of the neck, so we tend to do the proximal repair for these patients. So in this situation, we have modality to do the balloon molding to get a better position in terms of, in the case that we treat intraoperatively and we found that the graft will not expand very well, or we do the reinforcement with the stent, also with the endo anchor, and sometimes we can fill the gap with embolization technique, with the coils, with the liquid embolization like onyx. Also, some report from China with the fibrin sealant can seal the sac also. This is a stent that we have, but unfortunately we don't have the Palma stent in our country no more, and then we can use the big graft filter. But let's say that the radial force will not be good as the Palma stent. This long-term follow-up, long-term data for mammals in patients we treat with the Palma stent in more than 100 patients, follow nearly 4 years, and they still have good clinical success after 3 years. And also, but even you get the seal at the beginning after fixation of the endoleaks, it's not resistant to neck dilatation. So we fed the problem like this. We could see a floating Palma stent later with the neck dilatations and also with the late proximal type 1A endoleaks. Get back to the endo anchors. In this case, we have type 1A endoleaks, and we try to fix the endoleak with the anchor. And I place the endoleaks at the anchor on this side. And then on the inner curve, you can see that we touch the ball very well, but at the outer curve, it still be there. So we miss the wall at the outer curve. So in this case, you have some endoleaks there. So we have to place the additional Palma stent to enhance the fixation at the proximal neck, and just improve the type 1A endoleaks. And after 2 years, the sac still remains stable and without recurrent endoleaks. So with the ankle registry, I think you have heard about that many times this morning. And actually that included 70 short neck patient also. But the outcome, if you see that the outcome, the ankle perform a bit better with the primary arms, better than the revision arms. So, and also most of the patient in that arm will be prophylactics. So we have to think about, probably we have to use it before it get the type 1A endoleaks. For the embolization, let's say this patient, 85 years old bedridden, and she came with a symptomatic aneurysm, and then getting worse of the DIC after EVARs, and gets caused by the type 1A endoleaks. In this case, we perform the embolization by our interventional radiologist, and then she's still successful at the initial sessions, but she came back with a recurrent type 1A endoleaks at another curve of the neck, and also require another coils and glue session that temporarily improved the chronic DIC. In the literature, so this embolization technique for type 1A endoleaks actually had a high clinical success at the beginnings, and with some recurrent and also some additional intervention required. But we have to think about that, the report here, that include many embolization techniques with the glues, with the coils, with the fibrin also. And this, I think this summarizes very well for the roles of embolization for the 1A endoleaks. I think this has a role in the case that we have failed the adjunct procedures, or we don't have adjunct procedure not available or not feasible, and also with the feature that that prohibit the patient from the complex repair, either the anatomies or comorbidities, and also in the urgent situations that use the co-embolization technique to improve the patient's setup and before. And if it fail later, if the patient still be fit, so consider more durable repair. For the short proximal seal zone, if they have a residual neck or have migrations and still have a healthy neck more than 5 mm, so you can have a choice to stay below the renal artery with some extension cuff. But if it's too short, with the late degenerations or no residual neck, so don't hesitate to go proximal with the proximal repair. In this case, showed at the beginnings of the talk, with migration or with the low deployment of the neck. So actually the patient has a neck, so we just extend the cuff. But if we have to extend with the fin of the branch for the type 1A endoleaks, the situation that we have to consider is more the same. Looking for the proximal, looking for a distal, the side branch we have to incorporate, and also the access route. For the proximal, we have to define it clearly because we need only the effective proximal sealing. We don't count the one with the barrier, with the bad stent, with some adjunct from the previous repair, or with some barrier, including the EVA stent itself, the Palma stent, or even the mouth position endo anchors that we not count as the good proximal sealings. And with this kind of previous adjunct, I think on the right side of the pictures that have the floating Palma stent, and when I place the fan and the branch, it just go outside. So you need to track of the passage. So, but it's okay because the bare from us, the bare expandable stent, anyway, get it done. With the previous adjunct, with the anchor, I think this morning we showed that just only 1 point something millimeter inside the lumen, but actually it include in case that you place it properly. But if you place it wrongly, probably you have more adjunct, more junk in the lumens. It depends. For the distal, you have a choice to seal in the main trunk of the graft. You can have a choice to seal in both iliac limb. Also, it's probably if you have distal degeneration, also you have a choice to go lower than the previous repair. This consideration, it will be the graft that used before, the pre-existing graft will be the bifurcated graft, or the AUI. The AUI have a shortened trunk, a shorter trunk and then taper. For the bifurcated graft, it depends on the stent graft you use. To summarize the device that we have, probably only the long body graft, we have few companies. Most of the graft, we have only about 5 centimeters for the main trunk. And this is not counting in case of the angulated neck, that when you place the actual length remaining is shorter than the actual length of the trunk. And also with the angulation, with the target vessel, because if you try to attack the branch, the target vessel with the branch graft, that have to taper the graft and you have to reflare the graft again to seal in the trunk. That may be too short to flare. And also this kind of example of the graft that you still can seal in the trunk of the existing EVA graft. But if you can't, you have to do reline the bifurcated limb. So you will be a problem with the short length of the trunk that they have available. And in the past, we have ordered the graft, the fin and the branch, the 2 components, with the fin and the branch graft, and also the distal bifurcated graft that should be and also must be done probably in the inverted limb fashions. And also this one. You have some options to do the fin and the branch on the bifurcated graft. And sometimes we have to order the dedicated branch, large one for the contralateral limb. This is a variance of the discal bifurcation to reline the whole graft. Another thing is the side branch incorporation with the barriers of the suprarenal band stent, and it's quite unpredictable to predict the relationship of the fenestration over that pre-existing suprarenal stent. Sometimes you have a gap, sometimes you can have some strut crossing the midline of the fenestration, and difficult to place the stent. So this will be a bit easier from the below, some target vessel may be a bit easier from the top. It depends on patient evaluation. It is very detailed if you have to do the planning by yourself. And even you can place the stent inside. It's not guaranteed that the branch will be patent because some compression, it can happen later, something you don't know under the CT. Probably this is the roles of the cone beam CT to check all these issues before leaving the operation room. This show the proximal band stent that we have right now in Thailand or in our region, I think. I think the most considerable one will be the lower 3 of them with the laser cut barb. That will be difficult to flare and to displace if the barb placed across the target vessel orifice. This will be the issue that we face later. And this also show that this barb make the technical difficulty during the procedure for the fin and the branch for the failed EVA. For the access route, the problem will be the scar from the previous access, and also the passing the device, especially the large device, through the pre-existing limb will be in the tortuosity, will be a lot of friction over there, and that can displace the limb. And probably we have to consider trans-axillary access to do through and through guide wire to get the better pushability and also the passage of the graft. And it shows that if you have this kind of situation, it's a bit scary to pass the device up. Probably prepare for some complication that can occur later too. With the literature, if we extend the branch, the cuff, the fan with the branch, or for the failed EVAs, have some literature that probably we think that is more difficult than in the native vessel, but actually it's quite similar to the native repair at the beginning. In the literature is quite very high technical success, and with this just probably a few weeks ago, with the more than 400 fever that for the failed EVA, nearly half of them caused by the type 1A endoleaks, with a very high technical success, with a very good 30-day mortalities with acceptable complication later. So in summary, if you want to perform the EVA, especially the high-risk anatomy, so you should expect some complication and prepare for future reinterventions, and then the lifelong surveillance is mandatory. And also the option, it depends. It depends on the mechanisms of the failure. It depends on the patient's situations. It depends on the anatomical factor and also availability of the technology that you will use. Enhancing the infernal seal, I think it's feasible in the initial phase, but later on it still will suffer from the late degeneration, and you will get to patient to repair the late type 1A endoleaks. And this we have to think about, should we use more liberally prophylactic endo-anchor or some adjunct to prevent this kind of complication in the long term. Thank you very much.
So thank you very much for the great talk from Dr. Kiattisak. So is there any question from the floor? And I would like to have some comment from the panelists. Dr. Hitoshi Masuda.
Yes, a very nice research and thought about the type 1 endoleak, but the situation about the device approval is very, very different from our country. So we have only usual stent graft and bare stenting for linear artery only approved. So our strategy is very limited. So how do you think about the selection of the open surgeries?
Okay. So that should be always the options. I think the open surgery can fix everything, but it depends on the situation of the patient. Let's say because I think initially if we have the failed EVA, we probably treat this patient because a little bit biasly because of the patient condition at the beginnings. And we have to fix the patient in the more sicker situation. It depends. If the patient still be, quite fit enough for the complex open surgery, you should go ahead with this one.
Okay, can I ask? Thank you very much. Very nice summary for all the options that we can use to treat the patient. But the choices that you mentioned, some of the choices are in different principles. Let's say, like majority of the options that you mentioned, like extended with the fan or branch, seems to be get more sealing, get more secure to prevent future problems. And then the other option will be less sealing, like coils and things. What's your suggestion? You when we have, let's say we have failed EVA, should we think about more sealing, more proximally, or should we think about the coil or endo anchor first or something?
Thank you. I think we look at the patient first. If you have the patient that quite frail patients with a lot of burdens of the disease up there, so even you can get a successful short-term outcome of the coils or the glue or something, it will recur. So if the patient still fit enough and have a reasonable life expectancy, so I'm not hesitate to go to the proximal repair.
I just one more question for you. So I think that usually the progression of the AAA is something like a very obvious in the long run. So should we like 100% put the endo and core for the case to prevent for the future event?
I don't think so in terms of economics also, because if we use the anchor, that means we want to stay below the renals. And also, if you look at the proportion of the patient that come to us, I think more and more complex anatomy. I think right now in our practice, maybe up to 30% that we push a little bit boundaries of the IFU or the infrarenal device. With the endoanchor, it can fix some things. We use the endoanchor primarily, prophylactically for the one that have a reasonable life expectancy, but with a difficult anatomy consideration for the fan or the branch, let's say small aortic lumen, also small target vessel. So I will stay with the endoanchor. If the patient still fit enough and he came back with the problem with the anchors, that means the patient has actually healthy enough to get more complex repair. So that we go ahead with the proximal repair.
Yeah, thank you very much. So thank you again for the great talk, and